My name's Michael Singer, and I'm clinical professor of ophthalmology at the University of Texas Health Science Center in San Antonio and director of clinical research at Medical Center Ophthalmology. We're going to talk about advances in the treatment of retinal disease, past, present, and future. And today we're going to focus on diabetic macular edema and retinal vein occlusion. These are my financial disclosures. So we'll talk about DME. Diabetic retinopathy in general. In about 2008, they did a study and showed that 1 out of 3 patients with diabetes have diabetic retinopathy. And this costs about $500 million a year. And essentially, the number of cases increased from 2000 to 2010 about 89% to 7.69 million. And probably now it's much higher. That being said, in 2011, only 57% of diabetics had the recommended eye examination performed, and the American Academy of Ophthalmology recommends yearly eye exams for patients with diabetes starting 3 to 5 years after diagnosis of type 1 and at the time of diagnosis of type 2. So this basically shows you that over time, looking at the big picture, you got 52 million patients with diabetes, and it comes down to about 500,000 to 1.5 million with clinically significant macular edema. So what's the management of this diabetic macular edema? Well, in the old days, we did laser photocoagulation. We now deal with anti-VEGF medicines, corticosteroids as well, and vitrectomy sometimes happens when there's macular edema secondary to vitreomacular traction. So let's talk about laser. Laser's been around a long time. The basic concept, we're putting high energy to create a burn, and we're trying to basically coagulate blood vessels. It does cause tissue disruption. It does destroy cells that essentially create angiogenic factors, and the goal was to preserve the retina. This is an old study that shows very clearly that using laser basically decreases your prevalence of severe retinopathy over time. This is a before and after a laser to a circinate ring. You can see laser in the middle where the yellow is. Next thing you know, after 4 months, patients have better drying and less edema. Obviously, the shortcomings, it's awkward delivery. We destroy tissue. You have to do it manual focus. You can't see what you're doing on a fluorescein angiogram. And the accuracy and precision is based on the physician-patient orientation. We have transitioned to the anti-VEGF era, which is anti-vasoendothelial growth factor. Vasoendothelial growth factor is what happens from anoxia. Essentially, if you've got problems with ischemia, think of it as putting a tourniquet on your arm. Your arm first gets red. That's essentially the VEGF, and then over time it gets swollen. So anti-VEGF medicines block VEGF. There are 4 anti-VEGF medicines we're going to talk about today. One is bevacizumab, which is off-label, known as Avastin. It's a fully humanized monoclonal antibody. It's not approved. Then there's ranibizumab or Lucentis. It's approved, and it was approved using the FDA RISE and RIDE trials. We'll then talk about aflibercept, which essentially acts as a decoy to VEGF receptor, binds both VEGF and PIGF, and essentially it's been approved using the VIVID and VISTA trials, and most recently Vabysmo, which is a little bit different because it's a bispecific, and what it does, it not only is anti-VEGF, it's anti-Ang2, and it was approved using the Yosemite and Rhine registration trials. So we're going to start with ranibizumab because this was the approved treatment. This is the RISE and RIDE trial. Essentially, it was looking at patients giving them 0.3 or 0.5 milligrams of ranibizumab versus sham. Essentially, it was a 24-month study with an extension of 36 months with long-term extension. Essentially, you can see very quickly that patients had improvement as early as 1 week, and at 6 months, they were at +9 letters versus 1.3 versus sham, and it went up to 11.7 letters and up to 12.4 letters. So essentially, with more shots, you got better vision. The sham never got good vision. And even when they crossed over between 24 and 36, although they doubled the number of letters from 2.5 to 4.5, they never caught up to 12.4. In terms of OCT thickness, it works as quick as a week. And you can see as early as 6 months, there was a statistically significant difference between the treated eyes and the non-treated eyes. And this maintained over time. And even when it crossed over, the difference was never as good as getting ranibizumab from the start. Something called the diabetic retinopathy severity scale, and you can see it runs from 1 to 10 based on the amount of diabetic retinopathy severity, where essentially patients who are 7, 8, 9, 10 of proliferative retinopathy, and scale 6, which really is 47 to 53, is severe non-proliferative diabetic retinopathy. And you can see below the swelling on the OCTs. What happens is anti-VEGF medicines have been shown to decrease the progression of retinopathy either by 2 steps or 3 steps. And we talked about those different steps. You know, essentially, let's go from a 6 to a 4 or 3 steps to 6 to a 3. And in the RISE and RIDE trials, approximately 39% of patients were able to get a 2-step improvement, and somewhere between 9 and 17% were able to get a 3-step improvement. Aflibercept were in the VIVID and VISTA trials. They were essentially two different schematics in terms of when to treat patients, whether it was at 4 weeks or 8 weeks versus laser. Primary endpoint was at 52 weeks. And you could see as early as 7 days, aflibercept did a great job of increasing vision in both the VIVID and VISTA trials, with essentially about 11.4 and 11.5 letters improvement in every 4 weeks, and somewhere between 11 and 9.4 letters in every 8 weeks, while the control never had improvement in vision. In terms of OCT, you could see as well, as early as day 7, you're able to get drying in both the VIVID and VISTA trials. In terms of 2-step improvement, you had about 38% in VIVID having a 2-step improvement, and about 28 to 32 had a 2-step improvement in the VIVID trials. So essentially, when you give more shots, you get better vision. And we're looking at, this is a plot that shows the more often you give shots, the better visual improvement you get. Diabetic Research Clinical Network did something called Protocol T, comparing these 3 medications, and essentially what they wanted to compare was Avastin, or bevacizumab, aflibercept, and ranibizumab. It was an NEI-funded trial, and they basically were given these 3 medicines according to a schematic that was proposed, that essentially if you were not dry or your vision was in 20/20, they repeated it. So essentially, most people got 6 monthly loading doses. Patients were 20/32 to 23/20. And you could see that initially in year 1, aflibercept was actually clinically superior to both ranibizumab and bevacizumab. That superiority decreased in terms of branded drugs versus ranibizumab, but still was statistically significant in terms of at 2 years being better than bevacizumab. In terms of drying, the same thing held, that at 1 year, the aflibercept was statistically significantly better than bevacizumab and ranibizumab. That statistical significance maintained with bevacizumab, but was not statistically significant with ranibizumab. So it regressed over time. It was really important that people who were in the aflibercept arm needed less shots, less rescue, and less laser. And we're going to move from that to what's the next molecule, which we talk about as faricimab. This, I mentioned earlier, is an anti-Ang2, anti-VEGF molecule. So basically, it has 2 heads. It's a combination medication, and the anti-VEGF, we know from looking at the other medicines, blocks VEGF and is good efficacy. The Ang2 may actually have additional anti-inflammatory activity because of the Ang2 process. And the bottom is a disabled FC, so it didn't cause a lot of immunogenicity. This was the original Yosemite and Rhine trials. Patients were given 3 different arms. The aflibercept were given 5 loading doses and dosed every other month based on label. There was a fixed Q8 week dosing with 6 loading doses, and then every 8 weeks. And then there was something called personal treatment interval, where patients got 4 shots, and then patients were actually treated like real life. If you were getting better, you would actually keep the interval going. If you suddenly had stability, you would start extending the interval over time. And then if you got worse, you would contract the interval. And essentially, it went from Q4 to Q16 week interval based on CST and BCVA adjustments. You could see very clearly that there was non-inferiority with all the arms, both in the Yosemite and Rhine trial. The difference was you were able to get to the point of having non-inferiority with less shots in the personalized treatment interval. If you look at it, both Yosemite and Rhine at 2 years, that 60% of people in Yosemite and 64.5% of people in Rhine were able to go 16 weeks. And if you go 12 weeks or longer, about 78% of patients were able to go 12 weeks or longer while keeping the great vision that they maintained that was equivalent to the aflibercept, as well as keeping the drying. And here's the drying over here. You can see that pretty much the graphs are superimposed on each other, both in terms of fixed dosing with faricimab as well as personalized treatment interval versus aflibercept in both Yosemite and Rhine. So in conclusion, this new molecule, which essentially is an anti-VEGF, anti-Ang2, was able to give more stable therapy while having longer duration of action. And the 1 year and 2 year data showed the fact that both greater than 12-week, you had 78%, and greater than 16-week, you had 62%. And the safety, there were no cases of retinal vasculitis or occlusive retinitis were noted. And they actually have an extension study called the RONEX program. There was a high-dose aflibercept trial completed for diabetic macular edema. It's called the PHOTON trial. And essentially, we went from 2 milligrams to 8 milligrams. And there was dosing over time, and there was a 1 to 2 to 1 ratio where you had aflibercept 2 milligrams every 8 weeks on label. You had patients who had high dose, which essentially was every 12 weeks after 3 loading injections. And then you had patients dosed as often as every 6 weeks, every 16 weeks after 3 initial monthly loading injections. The primary endpoint was at week 48. The secondary endpoint was BCVA for week 60 and 2-step improvement. And you can see here from the schematic, patients were given 3 shots for loading, and then they had a week off at week 12. And if you were in the Q8 week arm, which was on label, you got a shot, and then you were every 8 weeks. If you were in the Q12 week, you had disease evaluation, and based on your disease evaluation was whether or not you would be randomized to Q12 or Q16 weeks. And patients were randomized based on both vision and OCT over time. And what was interesting to note is that the majority of patients were able to be maintained at greater than 12 weeks, that you had 91% of patients that were able to be maintained at Q12 weeks in the high dose arm, in the moderate dose Q12, and the same high dose patients were able to go as long as 89% at Q16 weeks, which was really amazing because overall you have 93% of patients who went Q12 weeks or greater. So this is interesting because Yosemite and Rhine also had a large number of patients to go for longer periods of time. Now, remember, this is 2 different trials, and they had different inclusion criteria in terms of what required rescue. But the good news is that both these medications seem to have promise. The next thing we're going to talk about is steroids. And essentially, steroids are anti-inflammatory and may inhibit the expression of genes. And there are 2 types of steroid implants we're going to talk about. One is the dexamethasone implant, and one is the fluocinolone implant. Initially, steroids were approved using, they weren't approved, but they were tried using the DRCR network study, and they used triamcinolone. Essentially, that's not used anymore due to these implants. Why are steroids important? Because there are all these different inflammatory factors that are not touched by anti-VEGF medicines. Anti-VEGF does anti-VEGF and MCP1, but all these other things are just inhibited by steroids. So that's the other end of the story. Remember, I told you earlier that essentially I could put a tourniquet around your arm. It would first get red, and then it would actually get swollen. Well, the swelling is controlled by the corticosteroids, while the redness is controlled by the anti-VEGF agents. Ozurdex or dexamethasone implant is a 0.7 milligram dexamethasone implant that is made with the Novador technology, and this essentially erodes over time, and over 6 months it dissolves to lactic acid and water. The MEAD trial was a trial where you tested dexamethasone versus sham. Patients were treated over 3 years. Patients were retreated at 6 months, and pseudophakic patients did really well, gaining 5.8 letters versus the sham at 1.4. Phakic patients didn't do as well until they started to get their cataract taken out. And here are your 3-line gainers, 22% versus 12%. You should know that most people in the study had already failed anti-VEGF agents. Essentially, there was a lot of cataracts over time, and the cataract rate increased after the first year of the trial. When you took the cataract out, patients got to see better, and you could see baseline to cataract, they do very well. Then they actually lose vision when the cataract comes out to 9.6 letters, or essentially going up from 14.9 down to 9.6. Taking their cataract out actually improved their vision to 4.1, and then 12 months after their cataract surgery, they got 6.6 letters. IOP is what keeps you up at night. The IOP was well controlled in terms of the fact that if you had an IOP spike, as you went along during the trial, the IOP magnitude went down every single cycle. It should be noted that essentially that there was a very small incidence, one patient that needed IOP lowering surgery during the 3-year trial. We're now going to talk about Iluvien, which is fluocinolone acetonide, and the FAME trial. The FAME trial was approved for people who essentially were pre-treated with a course of steroids and didn't have a clinically increase in IOP. This is a non-erodible medication. It has a cylindrical tube. It's injected through a smaller needle, which is 25 gauge. The FAME trial was the registration trial. We looked at 2 doses versus sham control. They were randomized 2 to 2 to 1. Patients were 2050 to 2400. You could see at the 24-month and the 36-month, there was statistically significant improvement in visual acuity, which was definitely there at 24 months. It still maintained improvement, but it wasn't statistically significant. In terms of OCT thickness, just like the anti-VEGF medicines, this, fluocinolone implant dries people down very quickly and keeps them dry over time with relatively equivalent in 0.2 and 0.5. In terms of the cataract incidence, the 0.2 was approved, and you essentially had cataract extraction performed in 80% of people over 36 months. In terms of IOP over 30 was about 18.4%. IOP lowering medications was 38.4. Trabeculoplasty 1.3, and then IOP lowering surgery is 4.8. Now understand these patients were not pre-treated. As a result of this study, the steroid challenge was instituted. And essentially, you could look at what I just talked about. When you looked at the people who had the steroid challenge, what essentially was shown was that those people ended up not having any problem versus those who weren't steroid challenged, which is why, in terms of IOP lowering surgery, the FDA changed the label in such a way that patients have to have a steroid challenge. And we're going to go through the Paladin trial, which I'm the author of, in great detail. This is a comparison for glaucoma surgery and cataract surgery in all 3 steroids that have ever been used: triamcinolone, which was used prior to the implants, and dexamethasone and fluocinolone. And you can see that most people need cataract surgery when you put steroids in their eye, and usually it's 18 months. Glaucoma surgery was anywhere from 0.3 to 4.8. One of the questions that come out is, when do we use steroids? When would it make sense? The early analysis looked at patients being treated with anti-VEGF, something called Protocol I, and realized people present themselves relatively early in the process. Protocol I looked at different arms to treat diabetic macular edema. We're going to focus on the ranibizumab arm, the anti-VEGF arm. And what happens is people show themselves as early as 12 weeks. You're either going to be a winner, where you've got greater than 10 letter gainers, and that actually divides out into 10 to 14 or greater than 15 letters. You're going to be somewhere in the middle. Think of it as baseball. You got a single or a double, which is 5.9, 5 to 9 letter gains and about 23%, or you never strike out. You never get greater than 5 letters. What's interesting to know is that this presents really early, and you can look at the swim lanes, and if whatever swim lane you're in, you're going to stay in. If you are a winner, you're going to be a winner all the way through. If you basically never get greater than 5 letters, you kind of stay there all the way through as well. So you stay in your lane, and you can tell as early as 12 weeks. So obviously, the issue is you're less likely to achieve better vision if you don't get better vision as early as 12 weeks. So we talked about steroids, and obviously they have benefits. The benefits are they do affect a lot of different factors. The problem with steroids is you have to deal with increase in IOP, and the other issue is patients have cataract progression, and the vast majority of them over a period of time will get cataract extraction. So we're going to talk about the studies I told you up to this point were studies that were done for approval. I'm going to talk about 2 real-world studies that I wrote personally that look at both the dexamethasone implant, Ozurdex, and the fluocinolone implant in real life. So this was the reinforced study. We wanted to look at people in real life. So what happened when people were given dexamethasone mono or adjunctive therapy? And we looked at real world prospective data. We collected their data over a year's period of time. We wanted to see best corrected visual acuity. number of patients with 15-letter improvement, and area under the curve. What's interesting to note in our study, there were more patients that were pseudophakic than phakic, which is different than the other trials. The vision was count fingers through 20/20. CRT was basically 424 microns, so they were swollen. It's interesting to note that 93% of patients had previous DME treatment over time. So what we showed was that almost 50% of people only need one shot during the first year, but the mean was 2. And the average time between DEX injections was 152 days. It was used as monotherapy in about a little over half the eyes, and 45% received one or more intravitreal injections. Typically, it was an anti-VEGF medication. How did they do? Well, if you only needed one shot, you had 9.1 letters. If you needed 2 shots, you had 7.7. You needed 3 dexamethasone implants, you gain 7 letters. But these are patients who were previously treated, almost 93% previously treated. There was still visual potential in these chronically treated patients. In terms of OCT thickness, regardless whether you need 1, 2, or 3 DEX implants, you're able to drive the retina very well. In terms of secondary endpoints, you had 36% of people that were 15-letter gainers. The area under the curve was 3.6 letters. The maximum improvement was 11.7. The mean maximum range was 137 microns, and 20% of people got to 20/40 or better. Again, in a very chronic group of patients with diabetic macular edema. IOP issues were very low, actually lower than expected for this patient population. And when we break it down, about 12.2% of people had IOP greater than 25, 2.8 greater than 35, and IOP greater than 10 was 12.8. And there were no surgeries that were done to lower IOP. 22.8% of patients used IOP lowering medication. And this number is, almost half in terms of medication from the original MEAD trial. And here are all the adverse events. And in real life clinical practice, dexamethasone monotherapy and adjunctive therapy really helps these chronic DME patients. So there definitely offers some opportunity when anti-VEGF alone doesn't work. Now we're going to talk about another prospective trial called the Paladin trial, which was a phase 4 trial that I wrote using the Illuvian implant. Essentially, it was looked at patients prospectively. It was a prospective 3-year trial where patients were treated on label, which means they had a steroid challenge, 202 eyes, and it was actually to look at the incidence of IOP lowering procedure and IOP-related signals. There was also a retrospective 3-year look back to see how they did. It was published in 2022 in the journal Ophthalmology. When we look at patients, what's interesting to note, as opposed to the FAME trial, which I told you earlier, where you had the majority of patients being phakic, it was the opposite in this real-life trial. 85% of patients were pseudophakic. A third of them had 20/40 or better, and a third of them were relatively dry in terms of 300 microns. So this is a much more well-treated group of patients. What's interesting to know is 3 years before, when we treated patients, they actually lost 6.4 letters, and about 40% of people needed 3 to 5 injections. And overall, you needed essentially 65% of people needed more than 3 injections. It's only 35% needing 0 to 2. However, afterwards, the opposite happened. Not only did they not lose vision, they actually gained 4.5 letters, and about 68% of people only needed 0 to 2 treatments a year, with the vast majority having less than 5, which was the other way around. How did they do in terms of needing rescue treatments? Well, 25% of people didn't even need rescue over the 3-year period of time, with the vast majority of people who needed rescue treatments were either anti-VEGF or steroid, but it was statistically significant in terms of decreasing the number of rescue treatments or supplemental treatments in each of these groups before and afterwards. In terms of better control, you had better control of OCT thickness over time in the patients who actually had less treatment. So if you needed less treatment, you were better controlled, and you had more percentage of eyes under 300. Well, in terms of the steroid challenge, I'm going to introduce this concept of positive predictive value. And what it is, what's the chance of you getting IOP over 25 if you never had it before? And it turns out if you never got an IOP before the fluocinolone implant, there was an 80% chance, 77% chance to be exact, that you get an IOP, not get an IOP over 25. and about a 97% chance that you would not get an IOP over 25 at the last visit, meaning that if you did get one, we controlled it well with medication. Overall, the IOP was well controlled. The things that people worry about are the buckets, 21.7% IOP greater than 10, about 24% IOP greater than 25, about 11% IOP greater than 30, 2% trabeculoplasty, and the incidence of IOP lowering surgery was 3%, which essentially was much less than the FAME trial. And only half of these people had IOP lowering surgery due to steroid-induced ocular hypertension. Half of them were neovascular glaucoma, and only 20% had IOP lowering medication. Again, this steroid challenge decreased these IOP effects by about 50%. So essentially, using the fluocinolone implant was able to increase visual acuity, decrease the number of rescue therapies, reduce macular edema, and it showed that it was safe, and it really provided a durable treatment option for patients with DME. We're going to switch gears right now and talk about retinal vein occlusion. Retinal vein occlusion can be brought into central or branch, and hemiretinal vein occlusion is somewhere in the middle, and each of these get broken down into ischemic and non-ischemic vein occlusions. There are lots of risk factors out there. It could be age, systemic disorders, inflammatory disorders, hematologic disorders. In the old days for CRVO, we used to watch them. And in the old days, we used to laser them for BRVO. Now we use anti-VEGF and steroids, similar to the medicines we talked about before. The VEGF inhibitors, we want to block VEGF. Retinal vein occlusion has the highest amount of VEGF in any of the diabetic diseases. So blocking VEGF is a big deal. You can see that essentially in retinal vein occlusion, you have turbulent blood flow, thrombus formation, increasing VEGF, increasing leakage and edema, and increasing capillary permeability, breakdown of the blood-retinal barrier, which essentially goes from a nice dry retina and normal, and you can see the OCT with the BRVO. Ranibizumab was approved, for AMD, RVO, DME, diabetic retinopathy, and myopic degeneration. It's intravitreal injection. We have aflibercept, which is approved for AMD, RVO, DME, and diabetic retinopathy. And bevacizumab, again, like we spoke earlier, is off-label, but it's used typically in DME, AMD, and RVO. There are a number of different trials out there that got approval. We're going to go over them for the different approvals that were there. The Bravo trial was for branch vein occlusion using ranibizumab. There were 397 patients. Essentially, they were brought down into 0.3, 0.5 in sham. You could see that essentially patients were randomized 1:1:1. Patients could have laser retreatment if their vision was greater than 20/40 or OCT was greater than 250. There was a 6-month primary endpoint and a 12-month safety endpoint, and you could see very clearly that ranibizumab does a great job as early as day 7 of increasing vision versus sham, and 18.3 letters versus 7.3 letters in the ranibizumab arm, which continues over time. Once they had PRN treatment from month 6 to month 12, the sham group got better vision when you cross them over. Promise it never caught up. The same thing could be said in, we look at patients who are 15-letter gainers. You get it as early as day 7, it goes up to 61%. And although when you cross people over, they do better, they never catch up to patients treated initially with ranibizumab. In terms of OCT thickness, it does a great job of drying. Again, at the 6-month, we transfer people over. You transfer people over, they still don't do as well as being treated initially. The CRUISE trial basically looked at the same thing, except with central retinal vein occlusion. Same basic design. There was no laser rescue because laser wasn't a standard of care. These patients essentially, from the start, the sham arm gained nothing. Meanwhile, the ranibizumab arm gained 15 letters. Pretty much held steady over time. When you cross people over, the sham arm did better, but never caught up to the original ranibizumab arm. Same thing for 15-letter gainers. And basically, in terms of drying, did a very good job of drying initially the ranibizumab arm, and then when people crossed over, they got dry as well. Aflibercept, this essentially was for the branch vein occlusion trials, and they were randomized to either aflibercept 2Q4 or laser, and we looked at 3-line gainers and secondary endpoint. It was again a 24-week trial, then at a 52-week safety endpoint. You could see 52% of people were 3-line gainers in the branch vein occlusion aflibercept arm versus half as much in the laser arm. Essentially, You looked at 15 letter gainers at 52 weeks. Patients ended up, still maintaining their good vision in the aflibercept arm that went from Q4 to Q8 weeks, and the laser arm, they got a little better, but never caught up to aflibercept. You can see the BCVA over time. People gained vision as early as week 1 and 17 letters versus 6.9. And you can see that, and this is from 24 to 52, the aflibercept kept at 17 letters, and you did have some improvement in patients who were crossed over. OCT thickness, the same thing happens. You have great drying from aflibercept as early as day 7, holding out to week 52. Patients have a little bit of drying in the laser arm, but when they cross over, that's when they get the real improvement. In terms of CRVO, there was the Galileo and Copernicus trials, and they were randomized. They were against sham, because remember, sham was the treatment arm at that point, and Galileo patients were allowed to get retreatment after 6 months, but Copernicus, they weren't. And you can see the difference of the two different arms. And you can see that you've got Copernicus gives more than 50% three-line gainers in both week 24 and week 52, while the sham patients were 12.3, and it went up to, when you could give people rescue, went up to 30%, but never caught up. The same thing, we look at Galileo, that essentially the sham stayed where it was from 22 to 32, and then the patients who were given aflibercept had 60% improvement. In terms of improvement over time, in terms of BCVA, you've got 17 letters in the Galileo, in the Copernicus, and 18 in Galileo, and that maintained over time. In terms of change in central retinal thickness, patients treated aflibercept did a great job of drying in both trials. There was an extension trial to say, look, what happens over time, where we treated people, and what happened was from week 52 to week 100, we gave less shots. We actually gave more shots in the sham arm than the initially treated arm, and the median number of shots were 7 and 6. Patients fell into lots of different buckets. You could treat people at will, and you can see people got different shots depending on the individual. There's nothing that predicted them. It turns out the vision that you gain by giving people treatment on label, when they went down to PRN, even in the grade aflibercept, never did as well. So they went down. This is similar to other AMD trials, where we look at giving people less frequent trials, or in DME, they end up losing vision because you have to give it early and often. The thickness, however, did maintain itself pretty much over time. When you look at the percentage of people who were three-line gainers, or actually, sorry, percentage of people with dry retinas, they started to go down when aflibercept was given less often. So essentially, the great improvements you got have to be maintained with multiple dosing over time. Let's talk about steroids. We're going to talk about dexamethasone implant. Initially, we've gone over this. It's a preloaded applicator. This is the complicated trial study, but actually, really, it was essentially 2 different doses of dex versus sham. You can see that people gained vision about 10 letters as early as day 60. What happened was the vision then went down when the medicine wore off. Initially, we thought it was a 6-month medicine. We now think it's closer to 3 to 4 months. When people were rechallenged, however, they still increased the vision. The sham was crossed over, just like everything else we've told you. When you cross people over from sham, they do well, but never as well as the initially treated group. There were 20% of what I call one-hit wonders, because their retina was dry and they were 20/20. They only needed 1 shot. In terms of drying, it does a very good job of drying. The 700 milligram does a better job than the other doses, which is why it was continued, both at 90 and 180. IOP is what keeps you up at night. You can see very small numbers of patients got IOP. When the IOP went down, even, we're going 35, 25, or 10, it would peak at day 60 and then go down by month 6. And that's why we follow people at 2 months to see when they're going to have their IOP rise. In terms of IOP-related procedures, they were very small. In the 700 microgram 1.2, this, and even smaller in the 350 and some in sham. Cataract extraction, in the study eye for 700, there were about 4 people, and then 5 in the 350 that switched over to the 700. So these were the things that were approved. One thing I'm going to talk about is a new therapy that I recently presented at Subspecialty Day at the American Academy of Ophthalmology. It's called KSI 301 or tetramer. It is a combination of an anti-VEGF and a biopolymer, creating an anti-VEGF biopolymer platform or ABC platform. This is the trial. The tarcocimab is the medication, and it's tarcocimab tetramer, but we'll just say tarcocimab. Patients were given this versus aflibercept, which was given on label. Aflibercept was given monthly, while tarcocimab was given 2 doses and then every other month. So there was a match phase and a maintenance phase, and non-inferiority was the final endpoint. Patients were 20/25 to 23/20. They had to be swollen, and there was no specific exclusion for ischemic CRVO. The good news, even during COVID, you had very balanced arms, even though only essentially 95% of people stayed in, with 284 in each arm for analysis. There really wasn't a significant difference in terms of the groups for randomization. There were patients, most patients had BRVO versus CRVO. And then in terms of clinical trial results, tarcocimab did a great job of drying the retina versus aflibercept, and there was non-inferiority in terms of visual acuity with somewhere between 14 and 15 letters. In terms of drying, it did a great job of drying. When we looked at patients in all RVO, as opposed to what I just showed you in BRVO, that still held up somewhere between 13 to 15 letters and good drying, both being non-inferior for both arms. What's interesting to realize, in the real world, patients essentially need 4.5 to 4.6 injections, and that's what they typically get. Tarcocimab was able to give you these great results with less injections, 3.9 injections, while aflibercept had 5.8. So real world evidence, essentially, this is, underperforms. Meanwhile, with this medication, we seem to be able to get good results in both BRVO and CRVO. We're looking at this and breaking it down. You can see that in the match phase in the BRVO trial, it went head to head with aflibercept and did very well in terms of vision and OCT. And then in the maintenance phase, we were able to hold its own with half as many injections in both visual acuity and OCT. This was the same thing, not only in BRVO, but in all RVO patients as well. In terms of things like 3-line gainers, they were equivalent in BRVO and all RVO patients, the tarcocimab versus aflibercept. In terms of safety events, there were 4 cases of ocular safety events, but they were pretty well balanced versus the 2 arms. In terms of intraocular inflammation, these 4 cases, they were all treated with steroids and the inflammation resolved. There were no cases of endophthalmitis, and there were no cases of intraocular inflammation or vasculitis or vascular occlusion that were observed. These are the other safety, and they were well balanced between groups. So essentially, we talked about real world. Then in real world evidence, if you decrease the number of shots you gave from 6 to 4 in patients with branch vein occlusion or central vein occlusion, you would end up not getting as much vision as you typically would. It would be a reduction of 39 and 63% respectively. But tarcocimab could actually give you comparable vision while doubling the treatment interval from monthly to every other month while still maintaining good visual acuity results. So the Beacon trial, which what we talked about, was the first trial using tarcocimab to be non-inferior to aflibercept, using tarcocimab 8 weeks versus aflibercept 4 weeks, and it was good both in the match phase and the maintenance phase, and had a favorable safety profile. This lends more confidence with all the other ongoing trials that they're using in patients with DME, AMD, and diabetic retinopathy. In conclusion, we talked about multiple pathways being evaluated to improve retinal disease options. We built a better anti-VEGF molecule. We made sustained delivery. We used new mechanisms of action. We looked at new things that are in development. So in terms of diabetic macular edema and patient retinal vein occlusion, the future is really bright. So I'm very excited at what's going to come next. Thank you for your attention.
All right. So retina is the one field where there are so many syllables in all of the words that I definitely have an inferiority complex that comes out very rapidly anytime I listen to any of the talks. But Dr. Singer made that so understandable. Thank you, Dr. Singer. He is coming to us all the way from across the world in Taiwan and calling in. So thank you, Dr. Singer. who is hailing from, he actually practices in Texas in a very busy private practice where he collaborates with referring ODs, and he also serves as a clinical professor locally. So he devotes his time in a very busy retina practice, taking care of a numerous number of retina patients. And so much has happened in the last decade to 15 years, Dr. Singer, wouldn't you say, from where we started with maybe Macugen and just a little bit of laser therapy, and that was mainstay, was the creep of focal therapy. And now look where we're at. Wouldn't you agree?
Absolutely. We've made great strides in the last 15 years, and the entire treatment paradigm has changed. We used to do laser to try to slow the disease down and prevent visual loss. And now with the invention of new medications and injectables, we're now talking about visual gain. So literally it is a complete 180 in how we treat our patients.
And so many are interested with regards to diabetic retinopathy. Dr. Singer, you mentioned your involvement in the different studies. People want to know the algorithms as it relates to anti-VEGF, anti-inflammatories, even as it relates to what is sham? Are you actually placing a needle with anything? Is it just a needleless hub? So if you could tell us what your treatment algorithm is and how you collaborate to share these patients. Is it a watch and wait? What have you adopted in the last few years?
Elizabeth, I'm going to answer your last question first. When we talked about the clinical trials, the sham was essentially just putting the needle hub onto the eye, so nothing was injected in the eye. With the result of these clinical trials that I talked about before, we now look at the first line treatment for diabetic macular edema as anti-VEGF therapy. And obviously, we have a number of different anti-VEGFs to choose from, given the fact that a lot of our diabetic patients are working age and many of them have commercial insurance. We may initially have to go with bevacizumab because insurance mandates it. And depending on the insurance company, we may have to give anywhere from 1 to 3 injections because they want to do what's called step therapy. So we'll look at different scenarios based on potential insurance because it changes a little bit. Essentially, if we have to go through step therapy, we give 3 shots. What I want to know is the disease primarily VEGF driven, or is it a combination of VEGF and inflammatory? And one of the ways we figure that out is, can I get you dry with an injection? So I'm very big on bringing people back at the 4-week time interval. The reasoning behind it is that's the maximum time of when the medicine should work and wear off. If you're dry with the medicine you're on, we're going to keep doing what you're doing over time, and then we're going to start extending it from 6 to 8 to 10 to 12 weeks, depending on the individual. But if you're not dry, then obviously we need to figure out what's going on. So typically what I would do is I'll give you 3 injections, and if you're still not dry, I'll bring you back at 2 weeks, because the 2 weeks is the maximum time of effectivity of whatever medicine I'm injecting. So what I do is I look at the OCT, because that's the mainstay of what we use today. The OCT is what happens. So if you come back at 2 weeks after the last anti-VEGF injection, I look, and if you're basically, let's say you're somewhere between 50 and 100%. So essentially you're 80% dry. So what I realized is your disease is primarily VEGF driven, but I probably have the wrong anti-VEGF. So if I'm on bevacizumab, I may want to move to either aflibercept, which was our mainstay, or what's coming down the pike, and we just started using since really the beginning of October in the J-code, is faricimab. I think both of these medicines do very well and will help me figure out what's going on. But let's use aflibercept for our example. If we use aflibercept for the example, at that point we should see you get dry because essentially you just had the wrong anti-VEGF. You needed a stronger anti-VEGF. That being said, if I bring you back in 2 weeks and it's less than 50%, what I realize it's not primarily VEGF mediated, it's more inflammatory mediated. And what I would recommend, and we're going to have this discussion, is if it was before October, that we may want to put an anti-inflammatory medicine, usually a steroid. I'm not a big lover of triamcinolone Kenalog has a black box label that says you can't inject in the eye. And Triesence, the problem is you get a bit of a snowstorm. So the patient complains of all these particles going by, and sometimes these particles can migrate to the front of the eye, giving what looks like a false infection or pseudohypopia. So that gets me nervous. So and plus, I know over time that if I give enough triamcinolone, everyone's gonna have an IOP spike. So what I've spent a lot of my time and written a lot of articles on is using the dexamethasone implant. The dexamethasone implant is very good because, number one, I know how long it lasts. I know that if I'm going to have an IOP spike, I'm going to have it within 6 to 8 weeks. I do understand that using the combination of both anti-VEGF and anti-inflammatory medicine, basically, let's just say aflibercept and dexamethasone, the majority of people will get dry. Obviously, understanding that it's going to last about 4 months, and we published that. So when these people are going to recur, you basically can give them pretty much a holiday with someone in the middle of that 4-month period of 2 months to check their intraocular pressure to make sure we can control it. At that point, when they come back, if indeed they re-swell up with this combination, I'm then going to give them another shot with a thought process that I may want to put a longer acting steroid implant, something like an Iluvien or fluocinolone implant, because the Paladin study does show, especially if they didn't have an IOP spike, that these patients may do very well in the long run. And the problem with our diabetic macular edema patients is they have a very high compliance issues because of a high no-show rate. We looked at patients who were getting shots for macular degeneration and for diabetic macular edema. Diabetic macular edema cancel more often and no-show more often. Why? Because obviously they have many more comorbidities to deal with. They have to go to see the doctor. The average DME patient sees 25 doctor visits a year. And considering doctors are really open 5 days a week, that's 6 weeks that you need to take off. And given this is a working age population, this is a real problem. So if we can do things that essentially will decrease the interval between injections, that's great. Obviously, people worry about the two side effects of steroids. One is cataract, and cataracts are curable, especially if any patient of mine is over age 50. There are these great multifocal lenses that basically will get you out of glasses. It's the only advantage of getting older. So, I'm not so worried about putting a cataract in a diabetic patient. Obviously IOP is what keeps people up at night. And if you look at the dexamethasone implant or the fluocinolone implant, we're able to do a good job of predicting when the IOP spike is going to occur. And if we keep people on IOP drops, we won't get burned. I ran a study looking at OCT RNFL in patients who had IOP spikes on dexamethasone implant, whether or not they had a history of glaucoma. And what we found very clearly was there was no difference between the eye that had the pressure spike and the other eye, over a year or two in terms of their retinal nerve fiber. So again, they don't end up with a whole lot of problems. In addition, looking at the fluocinolone implant, there was something called positive predictive value. And in those patients that you gave a steroid challenge to, the question was, what's the chance of getting an IOP over 25? And if you look at the Paladin study, 78% of people had IOP under 25 throughout the trial. And by the end of the study, 98% of people had an IOP under 25, meaning that if you did have an IOP increasing, essentially we could control it with medication. So again, that's a long-winded way of doing it, but I wanted to have the thought process on how to approach the patient, when to change the anti-VEGF, and then when to introduce steroids into the treatment paradigm.
So, unless it's somebody with out of control glaucoma or somebody with like an ACIOL where there is direct communication between the front and the back of the eye, an implant of a steroid is not really, you would say, contraindicated for somebody with that persistent DME that is more inflammation driven, non-responding to anti-VEGF therapy. Would you agree there? Is that what I'm hearing?
Absolutely. Now, I don't abandon the anti-VEGF. So to your point, if you have a CD of greater than 0.8 or an ACIOL, obviously, steroids are not for you. But again, one of the things I'm very big on is anti-VEGFs have a purpose. Even if they don't dry the retina, they do prevent progression of retinopathy. So I'm a big believer that if I'm going to use a dexamethasone implant, I'm also going to supplement with the anti-VEGF initially so we can control the development of proliferative diabetic retinopathy. But once I'm using something like the fluocinolone implant, there's some good data that shows that it does a good job of not only controlling inflammation, but also holding back diabetic retinopathy progression. And then at this point, once I know that these people are stable, I'll typically see them, at 1 month after the fluocinolone implant, but then every 3 months, just to make sure I don't miss anything. And then over time, if I don't see them, I also take a look and have one of other providers do it. The only other thing you should remember when you think about IOP, remember to check that corneal thickness, because the same rules that hold for open angle glaucoma also hold true for steroid-induced IOP changes.
Great. Well, from Dr. Singer's lips to everyone's ears, thank you for really making this much more digestible, especially during this QA. We really appreciate the time that you took to call in from Taiwan. We appreciate the time that you take to educate us. The raffle code, everyone, is IVT. IVT. Dr. Singer, have a great evening. And to all, have a great rest of the meeting. And we'll see you at the next clinical track lecture on refractive surgery update. See you soon.
Thank you so much, Elizabeth. Have a great day.